And I just want to thank you for inviting us and this opportunity to um, answer questions that help educate the team. And I'm going to turn things over to Stacy Kilgore, who's one of our senior education providers for prior auth, and she'll be followed by Jessica Bennett, who is one of our senior educators for medical review to help you better understand denials for interventional pain management and how to avoid. So all you, Stacy.
Thank you, Dr. Loveless, and good afternoon, everyone. I'm glad to be here today to assist Dr. Loveless with this information, particularly about prior authorizations concerning facet joints and spinal cord stimulators. So next slide, please. So I'll be talking about prior authorization and pain and prior authorization requirements for facet joint interventions as well as spinal cord. Facet joints were added to the Medicare Prior Authorization Program July 1st, 2023. And it has been a learning experience for us here at CGS on how to actually review these particular requests. With prior auth, we are asking for the documentation up front first rather than on the back end. And the documentation that we're requiring for these prior auth may vary depending upon whether or not it's the first MBB that's being requested, the second MBB, an RFA, or an intra-articular joint injection. So, but the things that we look for in documentation requirements for prior auth include documentation related to moderate to severe pain as demonstrated by a pain or disability scale, conservative treatments that have tried and failed, intended levels and region of the spine. If the request is for a second MBB, we need the results of the first MBB using the same pain scale before and after the procedure. For an RFA, we need the results of the first MBB as well as the results of the second MBB using the same scale before and after with the same agent that is used for both of those procedures. We need supporting radiological imaging. We need documentation that rules out other causes of potential pain for that patient. If it's for an RFA, we look for dates of when the last RFA was performed, and we look for documentation to show that that RFA resulted in 50% improvement in pain and or functioning lasting at least 6 months. If applicable, we need specific documentation on why an intra-articular injection over the MBB to the RFA, which is actually the preferred route. We based our reviews off of our local coverage determination, the L38773, Facet Joint Interventions for Pain Management, which is located on the Medicare database network. Next slide, please. So here's a documentation example for facet joints that we look for with prior authorization. And again, prior auth, you are requesting it, that particular service. Prior auth is a condition of payment. So we're just asking for the documentation up front this time rather than on the back end. So one of the things that we're looking for is those documentation examples I just gave you. And here on the screen here is kind of an example of a procedure note. We love to get these types of procedure notes because it helps us to see what was done, what levels were done, what region of the spine was done, what agent was used, what was the pre-assessment pain before the procedure, what was the post-assessment pain after the procedure. That part is very crucial because having that pre-assessment and post-assessment helps to substantiate the 80% that is needed to move on to the next procedure. If applicable in the documentation, we need specific documentation related to intra-articular injections, such as deformity in the spine, pseudoarthrosis, if there's an implanted device, something very specific to explain why you're going to do the IA procedure over the MBB or RFA. The other things that we look for in the documentation is when was the last MBB done? Per our LCD, the minimum amount of time that MBBs can be performed is 2 weeks. So we actually look to see when was the first one done in relationship to the second one. We look to see the HCPCS codes listed in the documentation. It's not enough to put it on a request form. We actually need to see something in the documentation that lets us know that this is the intended procedure you're going to do. what agents are going to be used, the region and levels. All those things are pretty crucial for prior authorization when it comes to facet joints. Next slide, please.
Can I ask you a question here? Just
Sure.
the slide back, the
Mhm.
previous one. The
On the
volume you're showing is 0.75% mark in 2 cc. This is one-sided procedure or bilateral procedure?
a procedure can be either unilateral or
Oh, this is
bilateral.
bilateral. Okay, okay.
Yeah. So we have in this example right here, it's bilateral. We do look for that as well too. So I'm glad you asked that question, because a session can be either unilateral or bilateral. And with these facet joints, there's a limited number of sessions that you can do for MBBs and for RFAs. So that part is actually pretty crucial because we're counting how many sessions has this patient had. For MBBs, they can only have 4 sessions per spinal region in a 12 rolling month period. So we do look for things like that. With RFAs, they can only have 2 sessions within a 12 rolling month period. And if an RFA is done unilaterally versus bilaterally, you can take up 2 sessions very quickly for that patient. And it will be difficult for that patient to get another RFA 6 months down the road if a unilateral approach has been done with those. So that's something to keep in mind. So that was a great question. Thanks for bringing that up.
So one of the, Amy wants to say that, please clarify that the pre-certification requirements are only for hospital patients.
Yes, it's for Part B service done in an A setting. So these are procedures that are done in a hospital outpatient department setting. Is those settings require a prior auth, whereas ambulatory surgery centers don't require prior auth, critical access hospitals don't require prior auth. It is only in those settings where it's in a hospital outpatient department.
But the criteria applies the same thing for us in private practice, in ASC or office, so we can avoid the audits and denials, etc. The same criteria.
Yeah, the LCD, yes.
Thank you.
Yes, that LCD is not only for the HOPD setting, but it is across all settings. But there is we have a billing article related to facet joints that gives a little bit more criteria on how your claim should be billed based upon your settings. So I do recommend taking a look at our local coverage article regarding that. Okay, on this next slide here, this discusses the top non-affirmed decisions that we've seen with facet requests that we've received in our jurisdiction for jurisdiction 15, which consists of Ohio and Kentucky. The major non-affirmed decision that we've given providers is that missing pain scale. We don't have a pain scale or disability scale that demonstrates moderate to severe low back pain. We're missing the same pain or scale used before the procedure and after each procedure. Oftentimes we get documentation where it just simply says patient states 80% improvement. How did you validate that? What assessment scale did you use to validate that 80%? That's the number one issue that we've seen with a lot of providers, that lack of documentation of showing that same pain scale before and after to support the 80% or greater. The next top reason for non-affirms is related to medical indication issues. We may be missing documentation. We don't have the procedure notes from the first MBB. We may be missing criteria for all 4 that's listed in our LCD. We may have that conservative treatments aren't documented, or if conservative treatments are documented, the documentation is showing us that those treatments are being effective. So it makes us wonder, then why are you doing this if this conservative treatment is actually helping? So we've also given this reason for an unclear plan. If in the documentation we can't figure out what you plan to do, then we may non-affirm the request. We've seen some documentation where they'll say, if this, then that, if that, then this. We've seen stuff like that. So we weren't sure if you were going to do an ESI versus an MBB. So if we get unclear plan, we don't know what levels you're going to do. The third most reason is the documentation does not indicate that it's going to be under CT guidance or fluoroscopy. While we understand that this is a given in the medical community, that these procedures are done under CT guidance or fluoroscopy, it is part of a limitation with it written in the LCD that if it's done under anything else, it would be considered unreasonable and not medically necessary, such as ultrasound, for example. So we do ask that question when we get our prior auth requests that come in to make sure that there is some form, something to let us know it's going to be done under fluoroscopy. So one of the things providers can do is they could actually list the HCPCS codes in their documentation, because the HCPCS codes actually defines fluoroscopy within it. So we take that as an example. You're going to do it under fluoroscopy. We've had some providers actually state it will be done under fluoroscopy, and it's really more for a patient safety concern rather than to try to annoy providers with that particular question, because it is outlined in our LCD. The next is documentation does not support clinical findings and radiological studies to indicate the primary source of the patient's pain. We have seen in recent radiological studies with some requests that the patient has a fracture in the very same area that they want to do a facet joint procedure in. And so it makes us wonder that that pain could be related to the fracture and not necessarily to the facet joint. And there's no documentation to let us know they ruled out the fracture. So we do look at things like that, or we see in the radiological studies that there is a mass there in the same spot that they're wanting to do a facet intervention at, and there's no documentation to let us know that that has been ruled out. Other things, the last reason that we see for that we will give a prior auth request a non-affirmed decision is related to excluded services. Sometimes people have given us ESI codes and those don't require prior auth. Or if there's limitations within the documentation as defined by our LCD, such as the physician plans to do another injection or another type of spinal procedure the very same day they're going to do an MBB, for example. We have seen some like that. And our LCD actually does not encourage that. So we may not affirm a request because we see that two procedures are being done the same day in particularly the same region of the spine. Next slide, please. And this just gives you kind of an overall look of the percentage of the amount of the top denials that we get for CGS for our jurisdiction. As you can see, the pain scale issue is the biggest reason why we end up non-affirming a lot of the prior auth requests. I do want to say that with the prior auth process, a provider can resubmit their request an unlimited number of times. There's no cap on it. You don't even have to wait a full month or 14 days like many private insurances may ask you to do. With us, you can actually fix the issue and submit it the next day if you need to. And we will continue to work with you to let you know why we non-affirmed something. And providers can always reach out to us at our education mailbox at J15A prior auth education at cgsadmin.com if they ever have any questions about their prior auth requests. And we provide one-to-one educational sessions for our providers in Ohio and Kentucky if they have questions about their request or if they have questions about the prior auth process in general. So pain scales is the biggest, and we continue to work with providers on that, offering them suggestions and tips that maybe they can go back and get, such as PACU, for example, when that patient's being prepped to go into for the procedure, was a pain scale taken before, was a pain scale taken afterwards, and oftentimes PACU do document things like that. So something like that could possibly help in getting that documentation that shows us a pre and post pain assessment for that particular patient. Next slide.
What percent of the requests are non-affirmed or non-approved?
Our current affirmation rate, and I'll definitely go over this tomorrow in that presentation with Dr. Berman, but our current affirmation rate is around 50 to 60% right now. When Facet Joints first launched in July of 2023, our affirmation rate was less than 10%. And we did lots and lots of education with providers. We had several webinar sessions. I conducted several one-to-one sessions with providers, and that affirmation rate has gone up. So now it's about close to 60%, I would say now, off the top of my head, where providers are getting their requests affirmed, and then it can proceed with the procedure for those patients.
That is much less than Medicare Advantage plans or commercials where they go through the same criteria. They apply the same LCD. And I don't know in general, but for us, our approval rate is like 99, 100%. So
I can't speak for Medicare Advantage plans or private insurances. Most of those insurance plans use algorithms. They look for kind of keywords in some of the documentation. Because the keyword is there, they'll either approve it or not approve it. With us, we don't use any kind of algorithm. When we are looking at our prior auth requests, we're using our clinical judgment. We use internal processes when it comes to these requests and provide much more stringent reviews of these requests and looking for everything within the documentation. So we don't just necessarily look at buzzwords per se that maybe a private insurance would look at, but it is proving our affirmation rate is actually growing, and I suspect that it will probably be much higher here in a few more months because we have evolved in our way of reviewing these prior auth requests.
thank you.
Next slide. Implanted spinal neurostimulators. This was added to the Medicare Prior Authorization Program July 1st, 2021, along with cervical fusions at the same time. With this one, we actually follow the National Coverage Determination electrical nerve stimulators. But for this, documentation requires other treatments have proven to be unsuccessful, including conservative treatments tried and failed. If applicable, documentation explaining why those treatments could not be tried. Clinical evaluations related to the patient's pain. We need at least a current H&P, progress notes, or office visits notes for those prior auth requests. The biggie here that we do look for in these is that psychological evaluation that's been conducted by a psychiatrist, a psychologist, a licensed medical social worker, etc. That can vary from state to state and what is allowed or who is allowed to do those psychological evaluations. We look for documentation to see how does their pain affect their activities of daily living. What's unique about implanted spinal neurostimulators, if the trial is going to be conducted in the same place that the permanent will be, then all we need is the prior auth request for the trial. We don't need one for the permanent if they're going to be conducted in the same facility. If, however, for some reason, the permanent placement is going to be conducted in a different facility from the trial, then yes, we do need documentation regarding that trial and that it resulted in 50% reduction in pain and or analgesic use for that patient. Next slide. So top non-affirmed decisions for implanted spinal neurostimulators for prior authorization does not include a psychological evaluation. This is probably our number one most challenging reason why we non-affirm for a spinal stimulator. We have seen documentation where the physician's office will use a preset psych eval questionnaire and it's the neurosurgeon or the pain specialist that reviews that and determines that the patient is fit for it. We cannot accept those. We actually have to have a psychological eval done by a psychiatrist, psychologist, a licensed social worker, etc. We cannot take a preset type of psych eval assessment that some offices utilize. Another would be it does not support a covered indication for implanted spinal neurostimulator, that there may be other issues causing this patient's pain. Documentation that did not demonstrate pain relief with a temporary implanted electrode. This is usually in those situations where they want to do the permanent in a different facility from where they did the trial. And when they hand us that documentation, the documentation doesn't demonstrate the trial did any good. So in our minds, it's like if the trial didn't work, then why do you want to do the permanent one? And again, does not show previous treatments have been tried with this particular patient for these. Next slide.
Do you require the post-lumbar has to be post-surgery syndrome or any requirements, or how about diabetic neuropathy or peripheral
Not
neuropathy due to chemical exposures or drug therapy?
when we're looking at the treatments being used for spinal, we look at all of it, what's been done, whether it's through treating radiculopathy symptoms, through medication, whether it's through physical therapy or any of those things. We look at the whole package of what's
But
been tried
surgery is not
for
a
that.
requirement. Pass.
Surgeries,
Okay.
yeah. If they've had surgery, we take that into consideration. Like if they've had a fusion, for example, in that region. Apologize, my dog here. Um,
That's good.
um, I was hoping she'd stay asleep, but no. Anyway, we do look at the whole thing. So surgery is not necessarily a requirement per se. We've seen some that have had fusions with it. We just look to see what has been tried, what's the whole overall package of what's been tried for that patient. Because oftentimes with spinal cord stimulators, it's usually a late or last resort option for many of these patients who are suffering some intractable pain. Here you can see here our affirmation rate is much better for spinal cord stimulators, but as you can see, our top reason, non-affirmed reason, is related to that missing psych eval. That's a biggie. We get a lot of requests, and they don't give us that psychological eval for that, and we really definitely need that with these particular requests. And our affirmation rate for spinal cord stimulators is pretty high compared to facets. Next slide, please. Rejections. This is a bit different. With prior authorization and a provider's received a rejection, rejections never make it to medical review. And oftentimes it's related to something wrong on the request form. These never make it. It may have had incorrect dates of service. One of the things that we will not affirm for or will reject for is if they put a date where it's already passed. They've given us a prior auth request. Let's say, for example, they submit a prior auth request today, February 10th, for service done on January 25th. We're going to reject it for dates of service because the dates of service have already passed. There is no retro authorization process when it comes to the prior auth program for Medicare. So when we see those, we oftentimes will reject for that reason alone. But these never make it to medical review at all. Prior authorization is a condition of payment. Any services performed without a prior auth will receive a denial, at which point you can then go through the appeals process if necessary. Next slide. Up next, I believe it's Jessica Bennett to talk about the Part B side of things.
There we go. Need to get myself off mute. So my name is Jess. I am the Part B Senior Clinical Education Consultant. So With the top denials for pain procedures, what we're most commonly seeing on the TPEE and prior auth side, fortunately, are very similar. Both we are lacking the use of the pain scales. I think I even have a documentation example where it's missing. So making sure if you are using templates, that is an element in the template, or if that documentation is coming from a nurse or someone else, making sure you grab that documentation when you're submitting your claims. We're also lacking that H&P. And this is especially common when the provider doing that initial assessment is different than the provider performing the procedure. So that's where we are seeing that quite often. So making sure that if you are not the provider that performed that H&P, it is in the practice to obtain that H&P. And quite honestly, I would advocate for you to get that H&P prior to performing the procedure, and making sure that's within your documentation. But definitely, it would be up to your practice to obtain that H&P if your procedure code is up for TPE or prior auth. We're also lacking the documentation of the procedure, that procedure note. Again, 100% templates are allowed per CMS, but also to keep in mind, you'll see this in the IOM, that they often lack the necessary elements to support all the medical necessities. So keep that in mind when you're using templates. We need to see that procedure note, what actually happened, what's going on with that patient. Number 4, we're missing that pre and post procedure pain scale. That kind of goes right back up to number 1. And then we're lacking the documentation of what percent improvement there is. And keep in mind within the LCDs, we need that percentage of improvement. And then number 5 is exceeding that frequency limits. We're seeing that quite often, especially with the epidural steroid injections. There's too many of them in that rolling 12 months, or they're too close together. So making sure that we're keeping that in mind when we're performing those ESIs. If you're using the MyCGS portal, that would be one area that your billing department or your office manager could look to see when was the last time they got that ESI, to make sure you're keeping track of those. The next slide, just some examples. ODI 15 days after that diagnostic facet, and other procedures done in the interim. How do we determine what procedure led to that improvement on the ODI? Another example is we're lacking of the scale to demonstrate moderate to severe pain at that initial assessment. Again, we need to see that pain prior to the procedure. And then again, as Stacy mentioned already, the psychological eval is not being done by that qualified provider, and we need that done by the qualified provider. I think that's all I really wanted to touch base on there. So we'll go into the next slide. Again, as I mentioned, the narrative is not matching that templated assessment. We will see in a templated assessment, 0 out of 10 pain. But then in the narrative, we will see that the pain is an 8 out of 10. When we have the documentation that does not match each other, as the reviewers, it's hard to take one area over another. We need to read and take the medical record in whole. So I quoted here that section out of the IOM, chapter 3, section 3.3.2.1.1. And actually, if you have office managers, billing departments, I recommend chapter 3 of the PIM to everyone. Everyone should be reading this. There's a lot of good information in that chapter 3 of that PIM, or the 100-08 of the IOM. So it just states some templates provide limited options and or space for collection of information, such as using like checkboxes or predefined answers. So a CMS discourages the use of such templates that, again, have that limited option. Claim review experience shows that limited space often fails to capture sufficient detail in clinical information to demonstrate overall coverage and coding requirements. So just keep that in mind if your office uses templates. Next slide. So here I have documentation, kind of a screenshot of a TPE that we did. And I know I'm a visual person, so I like to include screenshots whenever possible. With this claim, we ended up denying because the procedure note did not include the percentage or duration of pain relief from the prior ESI. So this was a recurrent ESI. We had no baseline pain scale. And then there were 5 ESIs done in the lumbar region in a rolling 1-year period. So as you could see in that first snippet I have, that we have pain level prior to injection, and it's blank out of 10. Pain level post-injection is blank out of 10. We have the results of this injection, but again, therapeutic isn't giving us that pain relief. They had pain in the back. Again, we're not seeing what that percentage of improvement is from their last injection. And then in the second one, we can see, or I should say the plan, the third one, she did get some relief. Again, we're not getting a number here. We're not getting a percentage. We will give her the therapeutic order for the ESI that she does get good relief from these. Again, we're not seeing a number here. We need objective measurements. Medicare is very big on objective measurements because we're not in that office with you. We're not seeing this patient. We can't see that, oh yeah, definitely there's an improvement where you're there, you can see her. And then, and just in the red there, I just kind of put the policy that wasn't met. So ESIs are limited to a maximum of 4 sessions per spinal region in a rolling 12-month period. That again can be found either on the My CGS portal or by calling the contact center. They can also provide that information for you, but I would recommend utilizing that portal. It's going to be your fastest avenue for getting that information. Do keep in mind that the portal is only going to have your PTAN information in there for billing history. You would not be able to look up if they went to an outside provider, outside entity. So just keeping that in mind. That could be attained through calling the contact center. How many that they had of that procedure code, you can never get other providers' information though by calling. So one thing I like to mention is adding that to your intake process. Have you been seen by any other providers within the last year? Have you had any back injections? Keep it simple. A lot of times these beneficiaries maybe don't even understand the concept of an ESI versus facet joint block, and keep it simple. Have you had any shots in your back in the last year? And then if they have, and they give you that other provider release of info, then you can go from there and see what they actually had done. No documented pain scale at baseline after each diagnostic procedure, and that kind of also goes in with the percentage of pain relief and the duration of pain relief. That plan down there, and that's all we had in this template. That plan was the only free form section of the template where they could have possibly have entered in any additional information. So it's a very limited template. On my next screen. So this tool is one of my favorite tools on our CGS website. So if you go out to our website and you go to Part B, and then on the left-hand side, you're going to be able to scroll down and you're going to see a medical review tab. And then from there, MR activities is going to be on the far right. And that's where you'll be able to see actually all of our current reviews. And spinal pain management is one of them. And within there, you can click on this documentation checklist tool, or you can click on it right on your screen, we share this. So I like this tool because if you are on review, if you are completing a prior auth, which I'll show that checklist in a few slides, you should be able to go down these checklists and mark yes for each one of them to determine if your documentation is present and is sufficient to meet criteria. Again, being able to mark yes is not going to be a guarantee of payment because that is done through the medical review. But just making sure simple things, name and signature of the perfect person performing the service. It is still, even in our world of EMRs, signatures are still the top reason for denials one of the top reasons of denials with CERT. So keep that in your mind. Is there order, intent to order be in there? And then, if you're looking at that E2, oh my goodness, 62323, the epidural steroid injection, there you should be able to go through those lines and check yes. Or if you're going to go into the facet joint, go down that line and check yes. The next screen just shows you a little bit more of the documentation checklist tool, a couple more of the facet joint interventions, and then the electrical
Do you
nerve
have a
stimulators.
requirement for when the imaging was done? Is it past 2 years or past 3 years, or change in the condition of the patient, symptomatology, or what criteria do you use on imaging?
So there is the LCD does not have a time frame for that imaging. However, definitely anytime there's a changing condition, and within the last year is going to have more weight than imaging results that were done 3 years ago, because again, people change within 3 years.
Yeah, and this is Stacy. With prior authorization, when it comes to radiological imaging, we take those on a case-by-case basis, depending upon the whole documentation in its totality. And just as Jess said, one done most recently will carry more weight than one done 4 or 5 years ago. And we've gotten radiological imaging dating far back as 8 years ago. And it just depends upon the whole package and what's going on with that particular patient. We've even had some where they've given us old radiological images, but the documentation shows us that the patient had a recent fall. And we'll question, wasn't there more recent radiological imaging done, because your documentation is showing us or telling us this person had a recent fall. So we also take that into consideration as well on the prior auth side of things. Sorry, Jess.
On the
No, thank
TPE
you.
audit, the most common reason why we failed the TPE audit, just one of our physicians, was that they didn't receive the letter written to the family physician that we were continuing the treatment beyond 1 year. I don't know if you want to mention that or not. That was the commonest problem what we have seen. So.
Yeah, we will be touching base on a lot more of those TPE, data and statistics with Dr. Berman's session
Okay.
tomorrow.
Okay.
Yeah,
Okay.
but yep, that was one that I did see come across my desk as a reason for denial. So making sure that the providers are having that constant communication with that referring provider is definitely beneficial. The next screen goes into this is for prior authorization. So they also have a checklist tool that's very similar to the one I just showed for TPE. And so it goes into the basic requirements, medical indications.
This goes more, this is
Yeah.
really more geared toward facets and what we're looking for with each type of procedure for facet intervention, from the MBBs to the RFAs. It even includes IA criteria in here. Our checklist tool for facets also includes some reasons why we may non-affirm a request. It also lists out the limitations as specified by the LCD. So this is, yes, like very similar to the tool that Jess showed you, but this is really centered around facets in itself and all of the procedures involved that require prior auth. And I do encourage providers to actually use this tool, because it can kind of give you an indication of whether or not we may or may not affirm your request. And you can find this tool off of our same cgsmedicare.com website. We actually have a prior authorization page, and we actually have a web page dedicated to facet joints, which describes some of the documentation basics. It has the link to this tool here. We even have a video on that site that goes into the prior auth process and facet joint injections.
So some of our key takeaways with the medical review with prior auth, document pain scales, just really hit home with your office. Are we getting these pain scales done prior to the procedure? And then making sure we're documenting those results and getting that documentation to the reviewers with those documentation requests. And then familiarize yourself, your office, your billing department with the LCD requirements, limitations. As I mentioned a few slides back, the Program Integrity Manual, or the PIM section of the IOM, especially that Chapter 3. It's got lots of good CMS rules and regulations in there that we as reviewers must follow. So a lot of that is not in the LCD, so you need to be aware of what's in the IOM and the LCD. And then next,
I think that's the end
there
of
we
the
go.
slides for this session. So I thank you both for going over that and for sharing your expertise. And it looks like we have some questions. So
Yeah.
Doctor, how do you want to do this? Do you want to read out the questions?
Yeah, I can read out the questions. So the first question is, for any procedure, percent improvement is more like a comment, I think. Percent improvement is usually higher the first month and diminishes by the second and third month. Which percent improvement is appropriate?
So I'll answer that one. So the percent improvement aligns with the duration of the anesthetic used for the procedure. So if the anesthetic was short term, then that improvement would be or of the injectant, not anesthetic. So for instance, if it had steroids, that would be expected to have a longer duration of improvement than a local anesthetic. So it makes absolute sense that that's going to diminish over time. And so that documentation should align with the duration of the injectant used.
But is that not accurate to just to document whatever let us say a patient says 100% relief for 2 days or 1 month, whatever he says, that much you relieve, and then they say 70% for another month or another few days and 50% after that. So that is what we do. That is accurate, right?
Absolutely. But for that 80% cutoff or 75%, depending on what you're looking at, as long as it's within the duration of the anesthetic, it's going to qualify for the requirements.
I think he's talking about a therapeutic procedure, but
yeah.
What is the duration you consider as normal for local anesthetic? Short acting is 2 hours and long acting 4, or?
Yeah. So, we know different people will have a little bit variation just in terms of their own response. But, if you do that assessment, the next day and they're telling you they feel better because that their injection, they felt better, and you complete the questions in your pain scale, then you've documented it. And as Stacy answered on one of the previous questions, that can be via a telephone visit or telehealth visit. It's just a matter of that being appropriately documented and those questions being asked.
But we require at least 2 weeks waiting period between the diagnostic blocks. So is that not better to see the patient after a week or something like that and then
I think it's better because they are going to give you more information, and you're going to have a better understanding if you targeted it. But the requirements for the documentation are aligned with the duration of the anesthetic.
Okay, thank you. The next question is, I had a patient that had both axial low back pain and radicular pain. Axial pain is more dominant. However, I had a prior authorization denial for facet MBB because radiculopathy was present. Is this part of LCD that patient must not have radiculopathy present or radiculopathy must be treated first?
So it sounds here like what so the LCD does it's I'm pulling up the exact wording so I can say it right, but requirement number 3 of the LCD, I'm gonna actually move this over to the screen so that way absence of untreated radiculopathy. So it is part of the LCD, it's part of the LCD requirements. And with the exception of the facet joint synovial cyst, at which point that would be anticipated along with the so in this case you'd want to be identifying the source of the radiculopathy prior to any facet intervention.
Okay. The next question is, if orthopedic surgeon can inject joints or nerves under ultrasound, why can't MBB for facets use ultrasound? Doesn't seem fair.
Well, I think that if there's a policy, for instance, if an orthopedic surgeon was to perform any of these types of procedures under ultrasound, they would get denied just like an interventional pain management doctor. So it's not specialty specific. It has to do with if there's a policy and what the literature supports in terms of best practices. So if they're doing that and that's not supported by evidence and therefore not reasonable and necessary for Medicare beneficiaries, it might be that a policy comes out and regulates that at some point, but it's not the expectation is that they're going to provide the best practices. So it's not it would be slipping through if it's not supported by literature rather than accepted practice.
Well, yes, when you framed the LCDs, we looked at all the literature, and there was extensive discussions on that before that decision was made. So then the next question is
their expertise in terms of those in all of those requirements. So it's all of them.
Well, theoretically, there is not actually a literature at all. They are here and there some observational studies, but it doesn't show that it is. And so probably it's not the time to go into it. But so the next question is why we don't get reimbursed for third level facet joint injection, only get paid for first and second levels. This is a similar question. So
I'm actually going to defer that question to the Q&A because I have some slides on that. And the facet policy is actually open and comment, and that's one of the areas. So that's the first thing we're going to address in the next session.
okay. The next question is continuation of ESI after 1 year. Is a formal letter to PCP needed? The office procedure note by a doc faxed over is not enough.
So and Stacy, please correct me if you have additional requirements, but the point is that there's a communication to the PCP. And the rationale behind that is that, sometimes these patients are getting a higher level of steroids, which may then, like if they're getting recurrent steroid injections, for instance, could that be kicking back and impacting their diabetic management or their osteoporosis management? So it's really about the holistic care of the patient and making sure the team members are all, you know, aware of what procedures the patients are having, and making sure that everybody knows, you know, what the situation is. But it can be a written letter, it can be sending it over from the electronic record, CCing the procedure note. I know my EMR system, when I was in practice, I could just put which, you know, PCP, and my note would just go right over to them, as long as I had their name in the referring doctor section. So it just needs to be that there's a communication, and that they're been informed and aware of the continuation of the services.
So is this a new LCD? Is this proposed LCD?
No, this is in here. Is one of the. Are you talking about ESIs?
No, here it says L30, the facet joints. So are we opening the comment period on that, or?
I'm checking this policy because I know it's in ESIs. I'm not sure.
This is facet joint interventions. It says proposed LCD, so.
Yes, this is the copy of the changed one. Yeah, this is the one that's open right now. And we'll talk about that in the next session. But the communication requirements in the ESI one, the languages.
And also, Dr. Loveless, I could help with that ESI question regarding notifying the primary care physician, because it is in the ESI LCD. I think it's the 13th kind of requirement, level D. And just, they need to be notified regarding continuation of procedures and prolonged repeat steroid use. And with that, it needs to be within the documentation that is being sent to the reviewer, that primary care was notified of those things. So just faxing them over a copy of the procedure note wouldn't be adequate if we cannot see that it was faxed over to the primary. So we need to have that documentation showing that it was faxed over, and that within that procedure note, it is documented that you are doing the continuation and prolonged services. So making sure both those elements are available within the documentation submitted with your review.
Perfect.
Does
Thank
that
you.
kind of help clear up that question? Yeah.
And I put that right here, the number 13 right here, if anyone wants to see the language within the policy. Okay, it helped you. It answered your question. Great. Thank you, Jessica.